Great. And so now it's a pleasure to introduce David Malkin, who I don't think really needs an introduction for this audience, to give us an update on this, on what the work they're doing in Toronto and screening.
So thanks very much, Sharon, and thank you, everybody. And I'd like to thank the organizers for inviting me. That does sound odd. But there were many people, as we said at the beginning, who have organized this meeting, and they were instrumental in making it a successful couple of days and another few hours ahead. Just as a point of after I'm done, we actually have a sort of a panel which is called Priority Questions. We're running a bit late, and because the whole afternoon is going to be based in a similar format, what we've decided is we'll have about 15 minutes for people to just really be able to ask some burning questions from the speakers who are still here from either earlier this morning or even yesterday. And so we'll just field those questions, and if there are any, and if not, then we'll still break at the planned time for lunch and then move ahead with the afternoon. So I also just wanted to highlight it is wonderful to see everybody here, and particularly to see a number of parents and family members from my own program in Toronto, and just to acknowledge them and point out that it's really nice to see you outside of the clinic. That's the way it should be. So we'll move along. This is the original 5 families who were identified by Drs. Lee and Dr. Strong back in the early or the mid-'80s, and followed, and then were recruited into the initial study that associated germline p53 mutations with the disorder. And the concept of these multiple cancers and the heterogeneity of multiple cancers goes along with the same thing that we've heard the last day and a bit of the heterogeneity and the wide spectrum of mutations, and how do we kind of reconcile these very complex phenotypes with very complex genotypes to try to manage patients more effectively, both in terms of screening and ultimately in terms of therapy and prevention. And that is kind of what led us to the idea a few years ago about developing at least some sort of surveillance protocol, or some attempt to determine not so much at the time of whether this would improve survival. That actually wasn't really what we were necessarily looking at. It was, is it feasible to actually follow and pick up things early? So we developed this, and we had the benefit of living in Canada, where in fact with socialized healthcare in a sense, we have never actually had an MRI scan rejected by our insurers ever. And that's not just for Li-Fraumeni. I think at the hospital for sick children, we have another study looking at all of our hereditary cancer predispositions screening studies, and we have over 1,000 MRIs, whole body MRIs, that have been done over the last number of years, and not a single one has been rejected. So there's a message. These are the challenges we've heard, and there are many, many challenges, but the ones that reflect on, we'll talk briefly towards the end of my remarks. This concept that the landscape of molecular changes in Li-Fraumeni tumors is really not well understood. We heard beautifully from Dr. Pinto earlier today about the adrenocortical story, and I think that one's going to expand much more broadly into all the cancers that occur in Li-Fraumeni syndrome. As well, we know that as yet we can't prevent Li-Fraumeni cancers. I'd like to think that for some of the work we've heard today that we're starting to break that challenge down little by little. We also are very aware of the multiple cancers, and we heard eloquently from Amanda earlier, and I have a number of patients in my practice, as many of you yourselves have, with multiple ongoing cancers. We don't have a very good way yet of predicting the ages of onset or the types of cancers, notwithstanding all the work that's going on. And we also don't have really very effective ways at treating these any differently than we do the equivalent cancers that occur in the general population. So these are enormous challenges, and I just like to bring them back out here as we head into sort of the lunch break in the afternoon, at least in my mind. And then ultimately at a molecular level, it's sort of like the first one, is it is still very curious that the cancers that p53 are most commonly associated with in the general population rarely occur in Li-Fraumeni syndrome. And we've heard a lot yesterday, some beautiful work that will help to understand why that is, but it's incredibly important that we do so that we can try to figure out how to treat these tumors more effectively. So this was the original publication. Anita Villani was a pediatric resident at the time and then a fellow in oncology, and worked on this very hard, and we published in Lancet Oncology. And just to clarify here, I did not call this the Toronto Protocol. One of my colleagues called it the Toronto Protocol, and that seems to have stuck, and I'm not going to call her out on it, but she's from Brazil. From the larger of the two cities that... So the protocol was designed intentionally to avoid any form of radiation, and also to identify through what we knew from the literature, from looking at individual tumors that we see in the disease, what kind of biomarkers, what kind of diagnostic imaging studies could be done that might be effective at picking up tumors, and that's what we saw. And we had it both in the pediatric and adult world, and we worked very hard with some of our adult colleagues, because I'm a pediatrician, to figure out if this made sense. And that was adopted by a number of places, adapted by a number of places, as we heard. But the original group identified a variety of tumors. Most of them were pediatric, and that partly reflects a little bit of a bias of how the study was done, based primarily out of a pediatric center. And I should point out that we had a lot of difficulty in our main adult cancer center in Toronto getting them to adopt, or actually just to technically adopt, the MRI protocol, because they could kind of scratch their heads and try to figure out how do you put 45 magnetic coils on a person in 45 minutes. And they worked it out. And this was, of course, the original publication, which generated an awful lot of attention and was very exciting. And I think we were all very cognizant of the fact that the likelihood of long-term 100% survival in surveillance patients was not likely to be sustained, but at least there was some hope that we perhaps had something here that needed to be pursued. So as of 2:05 yesterday, Anita submitted the second resubmission of our manuscript describing the update of the protocol, as well as a lot of new data, and we are waiting with bated breath to hear back from the journal. But in the meantime, I can share with you what we've done. So there have been modifications, and this is based, you'll see in a second, on some of the data, as well as interpretation of how best to follow. So in addition, for the adrenocortical carcinomas, with intense work from some of our endocrinology colleagues, we're adding the 24 urinary cortisol levels if they're feasible. These are a highly, highly accurate, precise way of generating data. And ultimately, if they prove to be even better than the blood work, then we might be able to get rid of the blood work, which would be kind of nice. And then the bottom in red there is, and this is getting to, I think what Maria Isabel had pointed out, and Fong had pointed out, and others, is this is not all about the MRI. Okay, it's not all about the MRI, and you'll see in a couple of seconds why. Extraordinarily good attention by really caring physicians to symptoms and signs in the patient, in yourselves, in colleagues, in everybody, are at least, if not more important, to figure this out. And it goes also to the concept of the VUSs and the, what do we call it, the benign variants, the likely pathogenic variants. If you've got somebody with a rhabdomyosarcoma at age 3 and a choroid plexus carcinoma, that's Li-Fraumeni syndrome. I don't care what the mutation is. I really don't care. We actually have had discussions in our own program where we've had families present with classic Li-Fraumeni, and there's no p53 variant. I mean, we've done whole deep sequencing, can't find it. And colleagues will say, okay, well, we don't need to bother with surveillance. I say, hold it. there's like 8 members with cancer in this family, and they all fit a syndrome. They still need to be followed. It just means we're not smart enough to know what the actual genetic alteration is. It may have nothing to do with P53, but there is still a hereditary cancer predisposition. So I think it brings back, mainly for the clinicians, it's at the end of the day, we treat patients, we observe patients, we don't treat the numbers. We use the numbers to back us up, but 85 to 90% of good medical practice is based on a great history and a great physical exam, and we use all the rest of it to just bolster what we should already know. That's my little, box speech, whatever you call those things. Okay, but we incorporated that a little bit more intensely into the new protocol. Now, the other thing is about the adrenocortical. It's very interesting, and hearing the data from Brazil is actually really interesting, because the SEER data would suggest that about 90% of patients with germline P53 mutations who develop adrenocortical carcinoma do so before their 20th birthday. And I meant to ask, and I will ask Fong after, is why the protocol at the NIH only starts at age 3. There may be reasons that I'm not aware of, but a bulk of the tumors that we see in Li-Fraumeni occur before age 3, including the adrenocortical carcinomas and choroid plexus carcinoma. So we have to be sure that we're capturing this very young age, because that's where we're going to find them. And because of that, what we've done for the adults is we've actually extended the surveillance for adults for adrenocortical tumors up to at least age 40, and some might argue, based actually on the Brazilian group, maybe they're probably even go beyond that because they're older. However, in the non-syndromic, if you will, non-Li-Fraumeni adrenocortical carcinoma outside of Brazil, there have only been 3 reports that I'm aware of a germline P53 mutation in adults, in older adults. I think out of the data out of St. Jude might be a little bit more. There may be a couple of more, but it's extremely small numbers, and so it goes to the balance of benefit and risk. And then much of the rest is the same. We have adopted the colon cancer, notwithstanding Thierry's comment there, which I think is very important, is who do you do? But we've dropped it to 25 years or 10 years less than the youngest. So in other words, if there's a family member who had colon cancer at age 22, we would actually drop the earlier colonoscopy. In Li-Fraumeni, we're not, but in some others, we're doing colonoscopies in familial adenomatous polyposis at 4 or 5 years of age, and finding multiple polyps and being able to deal with them. And then working with Judy Garber especially, we've adopted the breast cancer screening in particular, and are alternating annual mammography and breast MRI with the whole body MRI. So there's imaging every 6 months. So the MRI of the breast is alternating with the MRI, the whole body MRI, because the whole body MRI can also pick up breast lesions, and it's very intense, and there was a lot of discussion about this, but the general sense is that we have to be especially vigilant here. There is still the question of the whole body, about the mammography. It is it's radiation, very low dose radiation, but low dose radiation, as we've been hearing in the last couple of days, especially with the science, may be just as nasty as high dose radiation. So we have to watch that story unfold. And then that's it for that. Okay, so in the descriptive analysis of the study that we have here is sort of the data of what we had collected. These are the patients who were under surveillance, and you can see the numbers there are 40 in the surveillance group now, and there's more in the non-surveillance group. Basically no difference in gender, no difference in median age, and no difference in those who'd had previous malignancies. And here is the data. So there's 39 asymptomatic tumors have been identified now in 19 screen carriers of 59 who are undergoing surveillance. And of those 59, 19 crossed over. This caused much angst, about 4 pages of comments worth of angst from one of the biostatisticians who reviewed the paper, because this takes a lot of dancing statistics. It's legitimate statistics, it's just dancing statistics. All 19 of these individuals were diagnosed with they crossed over after they were diagnosed with cancer. So they were not being under surveillance for whatever reason. Their first diagnosis was made, and then they elected to switch to the surveillance study. So they basically ended up being monitored at that point. And what this is about is we are actually monitoring outcome based on the tumor, not on the patient. And that's actually an interesting concept to get around. We want to see what, at the point that the tumor is diagnosed, how long does the patient survive? Not the patient, it's the tumor. And so we've had to work a little bit with that. In the second group, you can see 63 symptomatic tumors were detected in 43 unscreened carriers, and those are of 49 patients. So a lot more tumors were developing in the unscreened carriers, although it statistically actually wasn't significant here. And there's the result. So 43% overall survival after 5 years. 5-year overall survival in the unscreened patients, and it's 84%. 3 patients, all actually children, passed away from their tumors, even though they had been followed by screening. And one of those actually had myelodysplastic syndrome. That was the third tumor that they had detected, went to transplant in an attempt to prevent transformation to leukemia, and unfortunately died of a complication of the transplant within a couple of days of the transplant, so not of the disease. One had a long history with adrenocortical carcinoma, multiple relapses, and ultimately passed away, as we know. And the third was also another child with a similar scenario where basically multiple tumors and ultimately succumbed to their last one. But at the end of the day, we have a significant p-value. And I think the message here is this is feasible in multiple centers, as we've seen. It's feasible over a long period of time, and I think Fong and Sharon have shown that in their settings. We are getting good compliance, and it does appear that survival is impacted, and this ultimately is a good thing. So, what about how the tumors were detected? Well, in fact, there's a whole hodgepodge, as we've seen. So tumors are being identified, whether they be benign, premalignant, or malignant, using a variety of the modalities that are in the protocol, with the exception of one patient that we're aware of where there was about a 2 to 3 month gap. In other words, one of the 4-month or 3-month imaging visits was missed, and so there was a larger gap. The time frame and gaps otherwise has ranged no longer than about 3 weeks, and we don't feel that that is medically a problem. Sometimes there's holidays, sometimes there's other things of like real life that intervene, and so essentially the compliance has been outstanding. But what you can see here is that a lot of the tumors are picked up by different things, and actually the number that are proportionally picked up by the whole body MRI are relatively small. A lot are being picked up by other modalities, and this is something to be aware of and to be particularly aware of where MRI is not really quite as available as it might be in some of the large cities that we're from. Okay. And then here's the concept of the spectrum of tumors. And here I want to point out that a lot of the things that are being picked up are actually what one considered premalignant or low grade, biologically low grade. And this is important. You'll see as this slide folds out that while just under half of the tumors that are picked up are malignant, there's a lot that are not. In fact, it becomes more striking when you actually put a number to it. So 24 out of 39 tumors picked up by surveillance are benign or low grade. And that compares to none of the ones in the non-surveillance. So in other words, every single patient who presented with a tumor in non-surveillance had a malignant tumor. And it may have been a lower stage, but there were a lot of high-stage malignant tumors in that group. There were no benign tumor or no pre-malignant tumors picked up in that group. And that, again, is another message. So what it appears is surveillance might be able to detect things before they transform completely. And these are just 2 or 3 examples. This is a picture MRI brain of a young 14-year-old who this lesion was detected. It sits right near Broca's area, which is the area of speech. And so the decision was this was likely a low-grade glioma. The surgeons went in, resected it, because the worry was if it grew, it would grow right into the speech area and cause problems. And it turned out to be a very low-grade glioma, and he's done well about a year and a half later. This is a young girl who'd had 2 previous leukemias, were referred to us from one of the other centers. We initiated surveillance. The surveillance popped up. This thing was an isolated lesion of the 5th rib, and that turned out to be an osteosarcoma. She was basically weary of all the chemotherapy she'd previously had and was fed up with that part of it. So we elected, with some brilliant surgeons, to take out the lesion plus the 2 ribs opposing it, put in a large mesh, and that was April of 2015. So she's a year and 2 or 3 months with having no chemotherapy for an osteosarcoma, and so far she's still symptom-free. And then this is a young girl with a very small anaplastic rhabdomyosarcoma sitting in the maxilla. It was picked up by scan, and this was resected. She received the low-risk rhabdomyosarcoma protocol, and she's doing well about 2 years later. And then this is a young boy with a malignant anaplastic rhabdomyosarcoma of the orbit sitting up here, right? For those here, up there. This turned out at the same time. His mother had just completed therapy for breast cancer, and so the story kind of came out. And we had shown around the same time with his patient that the type of rhabdo that occurs in these people with Li-Fraumeni, at least in the children, tends to be the anaplastic variant. He was treated. He actually had, because of the nature of the tumor, actually had to have the eye removed, but has clinically done well, except while he was on treatment for the rhabdo, he actually developed, this was picked up on surveillance. It's a adrenocortical carcinoma. This was small enough that it could be resected, and he did require more chemotherapy. He's now 2.5 years out with that. And then he also developed a low-grade osteosarcoma just in the orbit, and we're following that because that's clearly a very tricky area to deal with. But you know what? He's a happy camper, and he's doing really, really well. This was from a few months ago, but he's busy. And so this is the current survival curves, and basically to show that there seems to be a sustained plateau now on surveillance, and of course more studies are required to move that forward. Okay, so the idea is then in the last few minutes, I'll just show you where we're going, the sort of after the Toronto Protocol. But basically what we have is then the concept that one is born with a germline mutation in P53, which is either inherited or maybe de novo. And from what we've heard, we acquire or inherit a whole bunch of other modifier genes which probably play a role in how those cells start to behave and start to multiply and proliferate. And then other things happen. We heard a little bit about accelerated telomere attrition or telomere shortening, which can make those cells particularly unstable. The genomes become more unstable, and we have data, which I'm not presenting, which suggests that the changes in methylation, the epigenome, the parts of our DNA that basically protect the DNA and modify it, but not a mutation in the DNA itself. It's more alterations of the protective cover, if you will, are now thought to play a role in how P53 might behave. And then some catastrophic event happens. There's something called chromothripsis, where all the chromosomes just start shattering and rearranging themselves, which leads to these malignant cancer cells in which we see the ultimate transformation. But what we hope is happening is by putting surveillance in there, whatever surveillance is, that you may be avoiding that last critical step, a point beyond which there is no return. And so that's why we may see all these low-grade tumors. Okay, so these are sort of the conclusions from that part. We've heard that, and we do need to look very carefully at the economic and psychosocial impact, and we clearly need to develop more personalized precision approaches, and that's what the last couple of minutes will be. That just shows where the protocol. Okay, so starting with the mouse model, we actually are working with Gigi Lozano in Houston and developing using the p53 mouse and look for the idea, could we use circulating tumor DNA? We heard a little bit from Josh yesterday about this as an opportunity to do surveillance. And so one of the students in the lab, two of the students in the lab, Tanya Guha and Sangeetha Paramithis, have been working very hard at this. And what I just want to show you is Sangeetha is working in the mouse model, and she basically has now figured out a way that you can take blood from the saphenous vein, which is a long vein in the leg of a mouse, and get it down to 100 microliters of plasma. And that's like a teeny-weeny little amount of blood to see if we can find the DNA in such a small volume. Because if we're going to be doing this frequently, not just once a year, you need to be able to get small volumes. You can't be draining the mouse, let alone the human. So what she's found is we are looking for p53, mutant p53 copies. What we've done at the moment is just taken a tumor, we stick it into the mouse under the skin, into the muscle, and that tumor grows. Happens to be a rhabdomyosarcoma. And it happens to have a p53 mutation in it. And so what she's been able to show in a handful of these mice already is that there's the tumor growing on the black line. And here is, this is the axis for this circulating tumor DNA, that we start with very low circulating tumor DNA, and as the tumor grows, so does the volume of the circulating tumor DNA, essentially the gene that we're looking for. So we can look for total DNA in the mouse, which is going to be normal, but the nice thing about that is we know that's the tumor because it's actually human. We made a human tumor and stuck it into the mouse. So we know that's not mouse DNA that's floating around. That red stuff is the human tumor DNA, and so we know it's an accurate measurement that the ctDNA goes up. Okay, in this one, similarly, we have the tumor is growing like this. We have the mouse's regular normal DNA quantified here, and here we see the tumor DNA coming up. So the mouse DNA doesn't change, but as the tumor grows, so does the amount of circulating tumor DNA. And that DNA is coming from these tumors as they grow. Their cells die, they apoptose, they kill themselves as they were, and they release these teeny-weeny little volumes of DNA into the blood for a period of time. Here's another one where we actually see the tumor growing here, and then you can see the circulating tumor DNA coming up here. And then this is the one that is really the one we're looking for. Here, there's the tumor starting to grow way out here, and the circulating tumor DNA started to rise a few weeks before the tumor was palpable. And that is what we want. So this was the sort of slide that we all jumped up and down and say, hurrah, hurrah, and had a bottle of, no, we didn't have a bottle of champagne. But what was actually kind of interesting is the first analysis is all these mice were put into the same graph, and you didn't see any of this because you have to deal with each mice independently, and it was only that way that we were able to show, and Sangeetha was able to show, that you can detect microliters worth of, actually nanograms worth of DNA, tiny amounts of DNA in these animals. So this is a pilot study that allows us to start to think of doing this in the human. And so we know then that this is possible, and work by Nick Light, who's an MD PhD student here, is really trying to explore this. And the idea of this project essentially is to take, to identify, can we find a Li-Fraumeni tumor signature? Is there something about the genetic makeup of the signature that we could then measure in the blood, knowing then that it's a tumor derived in that particular patient? And if we can do that, then we could just use a blood test for surveillance. And those of us who are in this ctDNA world are finding this is a lot more challenging than we had potentially anticipated, and there's many ways. But the idea he has at the moment is sort of going backwards, is to take multiple biopsies from tiny little tumors, multiple regions, do deep sequencing, genetic sequencing, whole genome sequencing, and to try to create this architectural structure, molecular structure of the tumors, and then from that have a biomarker. And so the idea will be that we hope we would come up with something where there's X number of genes or variations which are unique to Li-Fraumeni syndrome tumors. Then with that information, we then go back to the other study, which is to look in the humans and to say, okay, let's look for that signature, following patients as they go along, and do that in conjunction with the typical surveillance, the imaging surveillance that we're already doing, and seeing kind of which is better, or which is more accurate, or which is more sensitive. And so this is kind of what his study design is, using all sorts of highfalutin things. The idea is you take multiple little sample biopsies of this little tiny chunk of tumor, and then the pathologist looks at it to make sure that the sample that we take actually has tumor cells and not normal cells, and then he goes ahead and sequences them. And so taking one of the examples, there's a patient we have in the practice with an adrenocortical carcinoma. He took biopsies of some of the adjacent normal tissue, so you can compare normal against tumor, and some blood as well, and then does all this sequencing on it. And from that, I was able to start identifying maybe there's a marker, at least one gene that we can use to follow that particular patient. So this particular project, at the moment, it was not designed for surveillance. This one was to see, could we use a marker in a patient to monitor their disease? And then we'll get to the point of being able to sort of do the work before. So we're all just at setting the stage, if you will, of finding what the molecular markers are. And so by doing that, there's one of the patients with adrenocortical carcinoma who presented with their tumor, and had a very large tumor. It was widely metastatic, in fact. Had a biopsy done, and then also had circulating tumor DNA drawn. And as you can see here, we draw them every single time they come into clinic. And that can be on therapy, of course, every week. And then in the concept of surveillance would be every few weeks. And what happens here is the patient got, here you see the circulating tumor DNA shot up. Oh my gosh, what happened? The tumor's growing like crazy. No, the patient got chemotherapy. And of course, the tumor just completely gets shattered. So cells are dying, being killed left, right, and center, and they're releasing all this tumor DNA. And so that's why it went up. And then it started to come down. There was a surgical procedure here where there was probably a release of some tumor as well. You can't avoid it. And so then you see another little peak, and then it drops down. She's been on chemotherapy for this whole time. And then here, the end of therapy, there was a little rise here, which we really don't know quite how to explain. And then it's basically dropped down to zero. And so now, coming up to many, many months later, currently in clinical remission based on imaging, and in molecular remission based on this. So this is an exciting opportunity for us that we will continue to pursue. And then the last couple of slides is just to show that we're also looking at different ways to do imaging. And so working with our radiologists, we now are exploring different ways of doing the whole body MRI with the diffusion-weighted imaging, which allows for different kinds of signal intensities compared to the what's called the stir imaging, which is what most centers use. And so if your centers are having challenges or difficulty with figuring out how to do the imaging, don't come to me. Well, you can come to me, but I'm referring you people to Mary Louise Greer, who's a brilliant radiologist and is working very closely with radiologists all around the world into getting the right technical specs on how the actual machines work so that the right imaging can be done. But what we're also going to explore in a research study is the use of whole body Pet MRI. There's only about 3 of these around the world at the moment, or in the States, and now 1 in Toronto. And the idea here is PET imaging is actually radiation, but it's extremely low dose as long as you don't put it together with CTs. MRI is very sensitive. PET tells you whether the little spot that you're looking at that we heard all about, these little spots, are they active? So if the PET lights up over a spot that is anatomically found by the MRI, that will give us much more confidence that this is a malignant lesion, whereas the PET is non-avid, and there's a little spot, you'd say, okay, it's probably a nothing. And that will hopefully save a whole lot of angst going forward. I don't like the idea because of the PET. It still is radiation, but it may be sort of an intermediary step as we improve technologies. Okay, and that's how we'll do it. Okay, so just before that, the Terry Fox Research Institute in Canada is supporting a lot of our work now. And what we've done is create basically a large team where we're doing the sequencing of all the tumors and the germline samples. We have some amazing computational computer folk, including Anna Goldenberg here, who is running these algorithms to try to do a lot of the predictive analysis that Dr. Cheng Chen talked about yesterday. Dr. Doria is doing our imaging. Adam Schlein also is very very heavily involved in all of the molecular analyses and that we talk about. And then, as Dr. Langenau mentioned, Jason Berman, who's in Halifax, also a zebrafish guy, we're developing some new zebrafish and mouse models of Li-Fraumeni syndrome. With that, I leave you with a picture of our happy family in the lab and the research group, and of course acknowledge everybody who's been collaborating and involved, and most importantly to all of us here are all of you out here. So thanks a lot, and have a couple of times for questions.
I had a question. You had mentioned about low-dose radiation. In your opinion, would it be a good idea for people like me to avoid, the X-rays at the airport, dental X-rays, stuff that? What is your thought on extremely low dose?
Right. So this is a great question. I think probably I'm sort of looking at Louise and Thierry and others, because I think this is one of the most common questions we get, and it's an important one. I think the general sense, at least, is that one tries to avoid radiation wherever possible. The fact that you may have flown here, you were exposed to cosmic rays in the airplane. Can't do much about that. Dental X-rays, they are extremely low dose. What I think I've been advising, and I'd be interested to hear what the others say, is generally you do them when you need them, but that's going to be definitely a lot less than what the dentist would otherwise generally recommend. And so it's more getting to that whole blurb at the beginning about the clinician paying attention to the patient and not worrying too much about the protocol of how to do X-rays. There's the Panarex, which is kind of the one time across, versus taking higher X-ray dose single shots. So that's, I think, generally try to avoid them as much as possible, but clearly if you need it, then you need it. It's not a risk. In terms of the X-rays at the airport, I mean, they insist that there's not a whole awful lot of dose there, but you can get a pat down. So again, it's where you have the option to avoid it. I think that's what we generally recommend. Whether those super low doses of radiation actually are relevant in the context of Li-Fraumeni in the human, we really don't know. There's some work going on. We're doing a number of others in the biology group to try to answer this. Does chronic very low dose radiation, is that a bad thing? We actually really don't know, and we need to understand it. Great question.
I have two quick questions. One is there any lab in Canada or the States that do the CTC test? I send my blood to Germany.
Yeah, so the ctDNA test basically is not a clinical test anywhere. There are a number of research studies going on, and the validation of it is nowhere close to ready.
Okay.
So there are a number of research, Josh has one going, we do, Thierry may, yeah. So there's a number of places that would be very excited and interested in working with you all to participate, but it's still very, very early days. Yeah.
Okay. And for women who have, and I know there's a gentleman here, who have had double mastectomies, do you still recommend then the annual breast MRI? And then whole body, alternating those?
Yeah.
Okay, just wanted to clarify that.
Yes.
Thanks.
Yeah.
Hello. I was wondering, with all the different institutions doing surveillance programs, is there an effort being done to combine all the data together? I know they're sort of doing it a little bit differently, but there are some key elements that you can break down the statistics with. Yeah,
absolutely. So as a number of them are basically coming to fruition in terms of the completing the study or completing their actual study to a point in time. So I think we all anticipate over the next few months there'll be multiple publications, and so we'll have a good sense of what everybody's experience is, not just from the talks that we've heard here, but the Australian group, the French group, and so on. And from that, the idea is to try to come to a consensus. Now, one thing I should say, there's actually a conference, not really a conference, but a small workshop which is being planned in, it's a closed workshop, but I'll explain why that is, by the American Association for Cancer Research in October of this year on cancer, on designing or developing standardized approaches to surveillance for a whole variety of cancer syndromes. This has just been started. The organization has just been started. And some of the people in this room who don't know this yet, but they are going to be there because they're on the list of invitees from all the major centers who are involved. So people like Fong and Marie Isabel and Louise and others. So the idea there is basically probably about 45 people from multiple centers from around the world to try to come to a consensus.
Great. And then just really quickly on circulating tumor DNA, could that ever be confused with somebody who's presenting as mosaic during treatment? Or are they separate? Are they different?
Yeah, so you brought a very good question. So the problem with circulating tumor DNA in the context of Li-Fraumeni syndrome is if the individual has a p53 mutation, then by definition, it's really hard to use that as your marker of the tumor because it's mutated in every cell. So there's two ways to do it. One is we talked about loss of heterozygosity. If the tumor loses that, you may be able to measure that the volume of p53 is actually half of what it would be in the normal blood. But aside from that, that's why we need to find other tumor markers that have nothing to do with p53 that are being expressed only by the cancer cells. And that's where the challenge is because we don't know necessarily, you get lots of different cancers with lots of different molecular changes. And it's not likely that we're going to be able to come up with something that, you don't want to have 50 different mutations that you have to look for. Ideally, you'd like to look for one little cluster.
Sure. Thank you.
Hello, David. Quick question. As you know, p53 is part of a family of proteins, and I've not heard any mention of p63 or 73, both of which can also be associated with Li-Fraumeni syndrome. And I'm just wondering if you have any experience or thoughts about looking at p63 and 73 in a similar sort of way.
So there is old literature that by a number of groups that have indicated there have been no documented mutations or variants identified in the p53 family genes. I'm sort of looking a little bit here to Pierre, just in case. Thierry, maybe you also, yeah, Thierry vanished. But I don't think there's anything there that we are aware of. They are associated with other syndromic features for sure, but not really associated with Li-Fraumeni, and even not particularly associated with a cancer predisposition per se, for the most part. But whether they play a role in modifying the effect of the p53 mutant is huge, and that's an area that has been relatively poorly explored, I think it's fair to say, something that we need to do. That's a good question, Wayne, thanks. So if there aren't any more questions, that's the end of this session, which it's about time for lunch, I think. Right, was 11:40 was? Yeah, so we are done this part. I just want to say before everybody runs off and gets something to eat, after lunch, we've got a fantastic afternoon ahead with a number of huge opportunities to really interface with many of the faculty who are here. I, unfortunately, am not going to be here. I have to head back to Toronto and heading out from there. But congratulations on an amazing symposium, and look forward to seeing you all next year. And next year, it's going to be in Toronto. So there you go.